Hi, guys. I just want to talk to you a little bit about Chapter 20, Documenting and Reporting. When we talk about documentation, it is the legal record of all interactions that we have with patients. It's the only permanent record of the care you give, of what you've done for the patient, and interventions you've taken, people you've notified, the only permanent document. It serves as a legal document. It serves as a way for us to communicate with each other. Communication is the primary reason that we have documentation. It helps us keep continuity of care consistent, so we can go back and look at the record and say, when was this done, when was that done. And it's vital. It's vital. We keep records of everything, vital signs, care we gave. We go in and put our assessments in, any kind of ADLs that we've completed. And quality improvement boards and legal folks do look at this, and they'll see if the standard of care was met. And the only way they can tell is if you've written it down, documented. If it isn't documented, it isn't done. So may have provided great care for your patient, but if you didn't document what you did, they can come back and say, well, you didn't provide this care. So I really strongly encourage you to make sure that you practice documentation when you're in your clinical setting. You study this chapter closely. It isn't always the most interesting thing to study because you're studying about documenting, which is kind of like, but it's super important, and it's going to take up a lot of time in your practice. So it's important that you understand why this is necessary. We also, now that most things in the acute care setting are electronic, it enables us to conduct research, more widespread research in large data sets, and also allows us to look back and see, what could we have done better in this case? How do we improve moving forward? So there's lots and lots of reasons why we document, communication being the number one reason. When we're talking about effective documentation, we need to record our observations, what we've actually observed, rather than our interpretations of those observations. So, for an example, you're not going to say a patient is kicking you and hitting you. You're not going to make an interpretation of that event and say, this patient is a horrible person, he's kicking me, he's hitting me. You're not going to make that judgment call. You're going to say, patient is agitated. Patient appears agitated, moving arms and legs, kicking at nurses, and slapping at nurses. You can put statements from the patient in quotes, like their exact words. If the patient yelled at you, "Get out of my room, I don't want you here," put that in quotes and quote the patient. That's very powerful for later. Should anyone need to see why you didn't provide care or why something was missed, they can see that. This often happens when we have family members who, as I've mentioned before, who will say, my grandma didn't get a bath yesterday. You can go back in and look at the record and say, well, she told the nurses she did not want the bath. She was very adamant about it, right? So when you're charting, always avoid generalizations. If you, like, even when I said a patient appears agitated, that's a generalization, right? I would follow that, like I said, with patient is kicking legs and reaching out with a fist, appearing to, or towards nurse's face, something like that, something very specific. If a patient, how can I put it? I've said things like patient throwing feces upon entry to room. Just very matter of fact. I make no judgment about it, and don't make any judgment. Your role is to just communicate it, write what's there in a very objective way. Don't make a judgment call. One thing that is really important when you're documenting, there's lots and lots of assessments, lots and lots of ADLs. And what I've seen nurses do is copy and paste their assessments in the EHR. Please don't do this. I have seen so much inaccurate charting from cutting and pasting assessments, because you've got to remember these EHRs have layers upon layers. You go into one section, maybe you say there's an abnormality in their pulse in their foot, and you go in under another layer and you keep documenting. There's a lot in there that you just don't want to copy and paste that. Who knows if it's the same as on your shift? I've seen patients have pulses documented for days on end in their feet when they had amputations and didn't even have feet. So, it just needs to be accurate. It needs to be your work. What I will do, in many units like ICU, you have to do an assessment every 4 hours, sometimes every 2 hours. So what I will do is the first one of the day, I do it completely, exactly what I saw, exactly what I observed, exactly what I heard in the lungs, what I observed on the feet. I don't look at anybody else's charting. I chart my own stuff. And then if I need to do another assessment 2 hours later, I will copy and paste my own assessment, only my own assessment, and go in and change anything that needs to be changed. Do not use anyone else's assessment or you will have errors. Just a warning. It is a very easy to get errors, and I found a lot of them. And when I find them, it's a feedback to the nurses. When an attorney finds them, it's seen as negligent care, inaccurate care. Well, how do we know that they did anything if they're all just cutting and pasting, right? Make sure you're factual, concise. You don't have to say too much. Just say what you need to say, and move on. This is important because it's important to chart as close as possible to the time that you did something to get your documentation in there. But we know that isn't always feasible. In an emergency situation, if we're reviving a patient, if we're doing a lot of things where we're in the room, we can't just say, oh, I'm doing CPR, I need to go document this as I'm doing it, right? It's just not possible. So we do chart later. Sometimes we will say late entry if it's late enough. Like if we go right after a situation and chart it, we simply put the time that we did it. If it's 8:15 and we did something at 8, we're not going to call that a late entry. We're going to put 8 o'clock and document. But say you went home or you waited, you got all your documenting done this morning and you forgot, like 2 o'clock in the afternoon, you forgot about something that you did at 9 o'clock in the morning. So you're going to go in and you're going to document it as a late entry. And the late entry, it will document the time that you actually documented it, but then you also will put a note there that says late entry done at 8:05 a.m. and then chart what you need to chart. And so it will show that, okay, she forgot, she went in at 2 o'clock and documented it from something from the morning. So make sure you document it as a late entry. The sicker a patient is, as busy as you are, the sicker a patient is, the more I try to stay right on time with their charting and caught up with it, because you can get behind and have a literal pile of charting that you need to catch up with that is very difficult to remember everything you did. So especially when I'm in ICU and I'm documenting every 30 minutes, I try to keep caught up as much as possible on that. It will be next to impossible to catch all of that up at the end of the day. Although and every nurse will tell you they have had days where they're literally charting everything late in the day. If you walk into a situation where your patient is very unstable and you literally cannot get away from that patient, it can be very difficult. But it's much better now that we have computers right in the room. They're not out at the desk. We can do everything right there in the room. One thing that I do when I am documenting in the room on my work station on wheels, the WOW, is that I make sure to face the patient, because then I can, especially in ICU, I can be monitoring their blood pressure, all of their vitals, all of their status. I can watch them for if they're waking up and trying to pull their ET tube out. I can watch all of that at the same time that I'm documenting. And some rooms, some facilities will have it so that you have two rooms next to each other in ICU, and you can open the window between the rooms so you can chart on one, be watching that one, and also keep an eye on the other one. Many facilities will have automatic, especially in critical care areas, will have automatic vital signs. They will automatically go into the computer from the monitor. The thing with that is you need to go in and choose the ones that are correct. Because when you have an A line, if the patient is sitting there and maybe they're waving their arm at you with the A line, that blood pressure is not accurate. You need to get the blood pressures that are accurate, save those, and get rid of the other ones. So usually there is just a prompt in the computer where you will choose the vital signs that you want to save for that patient. And it's very helpful if you've got someone on 15-minute vital signs or 5-minute vital signs, because they're in there. You just need to go in and pick the ones that are correct. If you're working in a system, as some folks will be in long-term care settings where they haven't brought in computers yet, you will be using doing it all on paper. And also in some psych facilities, I know they haven't brought in EHRs yet. I know Havenwick Hospital here it's right in Pontiac or the end of Auburn Hills there. It has not brought in electronic charting yet. Everything's on paper, but that is going to change soon. They're bringing in a system. If you're documenting on paper, really try to keep up with it. It's right there in front of you. You won't necessarily have a computer that's pushing information to it, so you just need to really keep up with it. I think what else. I will have on my daily brain that I carry, we all carry little pieces of paper that we call brains. I will keep little notes of times I did things, just tiny little scratches that I know what they mean. So if I need a chart later, I can look at them and say, oh yeah, that's what time I did that. So again, avoid copy and paste if you must do it, because you're working in a place that requires frequent assessments. Only copy your own. In acute care facilities and in most facilities, I believe now pretty much universally we're using the military time. So a lot of people are already familiar with military time. If you're not familiar, you've got to learn it and just know it. And it's really easy. You'll start thinking in it. AM goes from, it's usually 0000 is what I see for midnight. Here they have 2400, whichever one your facility uses. AM goes from midnight to 11:59 a.m. till 12:59 p.m. And then at 1 p.m. is 1300, then 1400, 15, 16, 17, 18, 19, 20, 21, 22, 23. So just make sure you're learning that, you're documenting in that. Most facilities use that, and you'll see that used in a lot of case studies. The 1900, you need to just know that that's 7 p.m. I think that's all I need to say about that. Just make sure you memorize that if you have not. One other thing back on where you can put a late entry in. Another thing that you can do is a mistaken entry, an error. And when you do an error, it's when maybe you charted something on the wrong patient. You've got your computer up, you've got Mr. Z's chart up, and then you just did something for Mr. X, and you didn't realize, that you went into the wrong chart, and you're charting a note on the wrong patient. So what you do with that is you go in. In the computer, there's a way that you just click on it. It will give you an option to say mistaken entry, and you just have to put a little note like charted on incorrect patient or incorrect time or whatever choice you want to make. If you're writing on a piece of paper in charting, you would put a single line through it, initial it, date it, and time it, and say error. That's it. You don't totally scratch it out. You don't make it so nobody can read it. You just put a line through it. Initial, say it's a mistaken entry or erroneous entry. Um, so remember that too. Anytime you have a mistaken entry, you have to call it an error and initial it. What is confidential? Everything. Everything is confidential. Your patients, the reason why the person's sick, treatments they receive, any kind of name, address, any kind of identifying information, uh, conversations in the hallway. You need to be absolutely certain not to, it's best not to have conversations about patients in the hallway. If you must, no identifying information should be used. Their name, their birth date. I don't even use any kind of, in the reason they're sick, that can be identified if they've got a very rare condition. People can overhear that and identify who it is. Um, Absolutely, just avoid speaking about your patients in the hallway when anyone else is around. Not to fellow students, not to your instructor. Go to a private space and then share what you need to share. Okay? And review HIPAA. I know you guys have all taken HIPAA. There is a great case study in CoursePoint. I will assign it. It's optional. You don't have to do it, but I'll assign it to bring it to your attention. That gives you a nice HIPAA review and on how you need to act to on the patient's behalf if you notice a breach of privacy. So review your HIPAA if you have not looked at it lately. You will use that every day. Know that you cannot even leave a voicemail. You can't text, nothing like that, unless you're on a secure line. Hospitals do have a lot of texting, but it's a line that's secure, and they're be very careful about what you put in those texts. Voicemails we can only leave if the patient has given us permission, and then leave minimal information. I am calling for XYZ. Please call me back at this number. And nothing that, because you don't know if their family member wants, if they want their family members to know their business, right? So be very, very careful with that. If you walk away from your computer and you leave it on and you're still logged in and your chart is up, that is a breach. That is a breach. Anyone can walk up to that computer and see that information. No social media, no sharing. Don't use any names on your clinical paperwork. If you must, you will be given some paperwork from your instructor. Generally, there will be no patient names on it. Sometimes we use initials. Never take photos or video at any facility of yourselves unless you're down in the lobby taking a picture of your group. Do not take pictures on the floor. Do not take pictures of any patients. You will lose your license and your place in nursing school if you do this type of thing. Even if a patient asks you to take a picture, don't do it. If they want to take a picture of you, let them do it. Don't you take that picture. You cannot access any chart that you don't have an interest, a care interest in accessing. So a patient you're caring for, you can go into that chart and look at that information. Even as an RN, if you are not caring for that patient, you have no right to be in that chart. Okay? So maybe you covered for someone at lunch and you need to document something. That's a care need, and you can go into that chart. But do not go into any charts that you are electronic or otherwise that you don't have a right to be in there. That is a breach of privacy, and you can and will lose your job for that, and often lose your license for that. If you leave something on a copier or a printer that someone accesses, that is a breach of privacy. So it's serious, and it should be serious, because none of us want our information to be out there where other people can find it. It's a true breach in our privacy, and in just it's violation of the law too. I remember I had a coworker back in the day who they had faxed her admission information to the wrong printer, and it came off in our department where she actually worked. And this was a private reason that she was admitted that no one knew about. And we shredded it as soon as we got it. We got rid of it. We weren't required to at that time because there wasn't HIPAA. And you would see people looking in charts and finding out information, and it's just, ugh, it just makes you sick to think about it. So just remember, follow your HIPAA. There are fines. There are fines associated if you breach patient confidentiality. But even more than that, it's just the effect on the patient and what you've done to them if you breach their confidentiality. It's invasive. Patients do have the right to their chart. You are not going to be the one copying it. I've had many, many, many people and patients and families come up to me and say, I need a copy of my medical record. Now, don't you go do all this. Don't go to the computer and print everything out. What you need to do is you need to direct them to medical records. And sometimes I will have someone from medical records or admitting come up and talk to them about the process rather than me getting all involved in it when I'm not the expert on it. They will tell them exactly what they need to do to get a copy of the record. They will, there's usually a fee associated with it, but they will talk to them about that. They absolutely have the right to see their healthcare record. But again, you're going to call someone above you, talk to your charge nurse about the process at your facility. Sometimes you need, they will want someone from medical records sitting with them as they look at their healthcare record. You just don't want to turn the record around and let them read it because there's so much in there they don't understand. I can remember we had a patient who got a copy of her healthcare record, and it was someone had written tachy on there, tachycardic, but they shortened it to tachy. And the patient was really upset that the nurses were calling her tachy. And they had to explain to her that's tachycardic, your heart rate was up. So there's all kinds of things that patients get confused about, and they need someone with them when they look at their record. Sometimes the physician will want to look at the record with them. So I think that's all I wanted to say about that. But the patients do have a right to them. If someone asks you for their record, talk to your clinical instructor and ask what the process is. And usually it will involve someone from medical records. And I would go in there, if I were you, when medical records is talking to them, to hear about it, hear about the process, hear about how it's done, because then you'll have more knowledge on that subject. There are exceptions to, with the patient rights, there are some exceptions to this. If someone is public health, does have the right to look at patient records for certain things. Law enforcement has the right to look at public records for certain things. They all need to come with the proper documentation to see those records. And in most of those kind of cases, I would always refer, if a police officer came up to me on the floor and said, I need to see the patient's chart, I would say, let me get my manager. And the manager could discuss it with them and go from there. Don't get into an argument. Don't say, I can't do that. Say, let me get my manager. We'll find someone who can handle this for you. Because you aren't familiar with all the paperwork that they need to have, but your manager probably is. One thing about HIPAA, it also does not apply to deceased persons. So once a person dies, their right to HIPAA is gone. So just be aware of that. That doesn't mean we start printing out their chart and paper putting it on the walls, but know that once a person is deceased, records are more available for different types of quality improvement, public health, things like that. All right. So when you, verbal orders should be very, very rare. Now that we have, especially in acute care settings with electronic charting, there is no reason that a physician cannot go in and put his or her own order in. Emergencies are the exception to this. In many emergencies, we will have a nurse who is writing down the orders, the recorder will be writing down the orders on a piece of paper as the physician is calling them out. And then in those emergency situations, often we will put those in the computer and the physician will co-sign them. because in an emergency, the patient taking the nurse taking care of the patient and the physician cannot be writing down those orders. But for most cases, verbal orders, we do not use them. They are only in emergencies. And it's good. They are error prone. We had many problems with these when we were in paper charting systems. Uh, orders can easily be misunderstood. They can be misheard. They can be forgotten by the physician. If you're calling someone at 3 in the morning, the nurse practitioner or physician, they can give you an order that they completely forget later. And I always urge folks, if you must take a verbal order, say it's 3 in the morning, it's an emergency, you need to get this verbal order, have another nurse listening as you're talking to the physician so that you can both co-sign that verbal order. The way you do it is you write exactly what the physician or nurse practitioner wrote. You write V.O, or in the computer there's a way to document VO for verbal order. You sign your name, and then you put the physician's name next to it. And then that order has to be co-signed or verified by the physician or provider within 24 hours. So sometimes we do that in case of an emergency when we've got we need to put restraints or something on. The provider's at home, they don't have good Wi-Fi, whatever the reason is, but then they need to be co-signed within 24 hours. So in emergencies we use them. Otherwise, if a physician is leaving the floor and says, hey, I forgot to put this order in, can you? No, you can't. It's not an emergency because they forgot it. It's only an emergency if it's a patient emergency. I think that's all I wanted to yap about there. Definitely, this is how when we happen to put an order or a verbal order in, it has to have you have to have a speak back on the phone when you're talking to them. When they give you an order, speak it back to them. Make sure it's correct. I've caught many errors just doing that, things that I misheard. Then you're going to sign it, your name, your title, and then you're going to put their name after it. And then absolutely the physicians and nurse practitioners will put their title next to it when they sign after you. Let me move on here. Most of us are using electronic records now. Electronic records contain all of the same sheets of paper that used to be in hard copies. They're just all in the computer now. Source-oriented records are types of records that are progress notes or narrative notes. These are really great notes to use because you can write out whatever you need to. Those are probably the most common ones that I use in addition to what we are required to use. You'll have required documentation. You'll have a sheet where you put your vitals and your ADLs and like bathing and hair washing and that kind of thing, and then also your assessment. Progress notes allow you to put anything down that happened during your shift that was unusual. So if I have a patient who say they crashed, their saturation level dropped, they had trouble breathing, I did a bunch of interventions for them. I will put all of those interventions in their proper places in the computer, where I put in an extra IV, I'll put that in the proper space, I'll put vitals in where they need to go, but I will also go in and put in a progress note about what happened because it paints a clearer picture. They found that especially if you're ever face litigation, that the progress notes really help explain the situation in the ways that are multiple pages of tables and charts don't. A great example of this is if you're trying to get a hold of a physician, a patient is not doing well, and you placed a phone call at 8 o'clock. I go in and say, provider, I put the name, Dr. Smith, called, left message with service, awaiting callback. And then when I talk to that physician, I'll put the time they called back and what we talked about. I will make it very clear. And if I've had to call multiple times, I will put each time that I've called. And if say no one's calling me back at all, I will go up the chain of command and say, 2 calls to physician have gone unanswered, charge nurse notified, house supervisor notified if applicable, and sometimes we'll go over that person's head. Sometimes if you're working in a teaching hospital, maybe you've called the intern and they're not calling back. then you go to the resident, then you go to the chief resident, then you go to the attending. And usually it's a thing where someone they're either in an emergency and they can't call you back, or they're so deeply asleep that they're not hearing their phone, or their phone is off, or has the charge has died down, something like that. But document every time, because it shows when you started to intervene on that patient. SOAP notes, be familiar with what they are, but know that those are used mostly by nurse practitioners, physicians. It's basically subjective information, objective assessment, and then the plan. It's a very complete way of seeing what's happening quickly. Charting by exception, you will see, be careful with charting by exception. It's fast, you get things done quickly, but it doesn't always reflect all of the care you've given. It basically, you go in and you chart abnormalities, right? Which is great. It's a quick way of charting, but then you have to be sure that everything is actually getting documented properly. Like, say you go in and you put within normal limits. I've worked at places where the assessments were done like this, and say you went in and for cardiovascular and you put within normal limits, but your patient actually is in atrial fibrillation. So you need to know the definition of what within normal limits means. You can't use within normal limits if there's anything off about that issue. Say your patient's got a completely normal skin assessment within normal limits. If they have an IV in, you have to document that. That's not within normal limits. We don't have IVs at home, right? So when you're using charting by exception, you have to make sure you know the definitions in your computer program for what within normal limits means. And then you can use it and you can go really fast. But it does increase liability risks often, because it doesn't always record the full care you're giving. So be certain, even if you've got charting by exception, that you're actually going in and making sure that everything is documented so there's a clear picture of what went on that day. So again, documentation is primarily a means of communication, but it's also the primary source of evidence for measuring outcomes and quality improvement, research. It's looked at by JCAHO, it's audited by JCAHO to see if the standards of care are being met. Random charts will be audited by folks in your facility, and it's used for reimbursement. If something isn't documented, it isn't done, and we don't get reimbursed for it. So we have forms in the computer that are for the initial nursing assessment when they come in from outside the hospital that are really involved. You won't be allowed to do nursing assessments or discharges as a student, but I encourage you to get in there and look at these documents once you're in the computer system at your facilities and clinical. You'll be able to see the types of things that you need to ask the patients, and your nurses might let you assist them some. And as you get more familiar with what's on the forms, you can almost talk to the patient like a conversation and get all of the information you need. You'll see a lot of flow sheets, graphic records for your vital signs, your intake and output. Your ADLs will be click, click, click. Yes, I did a bath. Yes, I did that. So it's very very intensive. There's lots of different forms, and you need to be aware of what your RN fills out on each shift. Even if you're not doing it, ask about it, look at it, watch them do it. There's a medical administration record where all your meds are given. There's a one that has scheduled meds and ones that has as needed meds, so make sure you're familiar with those, because if you're looking at your scheduled meds, you're not going to see any of your pain meds or your nausea meds on that sheet. You need to look at your PRN sheet. So these are all have different purposes. You'll see different types of documentation in home care and long-term care, because there's certain specific things that Medicare needs to know to reimburse care for folks who are on home care or long-term care. So those will be different. Often they'll be looking at what's their mobility look like. Are they able to walk a certain number of steps? Are they able to walk a certain amount without oxygen on and keep their SATs high? Those are things that they look at to see, okay, do they need a little more home health care? Do they need a little more long-term care? When we're discharging people, often for them to have home oxygen, this is a good example, we need to document that they have a saturation of less than 90 when they ambulate. So if you haven't taken them for a walk and documented that their sat is under 90 when they ambulate, they're not going to get qualified for home oxygen. So you need to be aware of some of those things and thinking about that and anticipating that with your patients. Transfer summaries, one of the big times when we have a lot of errors in care is during transfers. So I always am very careful to make sure that those transfer summaries include the correct medication list, because we find that medications will get doubled up by accident, they'll get missed by accident. So make sure that what you're giving in the facility is what the physician wants to have them have at when they go home or go to an outpatient facility, and make sure that they match what you're telling the facility that they're going to. Technically, physicians are responsible for this, but we're the ones who catch the errors, and there are a lot of them out there. I had a patient who my students were coding this little lady. We didn't know anything about her till later. It turns out the reason she came in and coded, she'd had a hip surgery about a month before, and when she went home from her hip surgery, her blood thinner was not restarted. She was on a blood thinner because she'd recently had a stent placed. And when she came in for her surgery, she was off of the blood thinner for the hip surgery, and she didn't tell anyone about it. So when she went home, it was never restarted. I always say that great nursing histories are what keep that from happening. If you have a patient, she had an MI and a stent placed a few months before. So when I go to discharge that person, I'm looking at this going, wait a minute, when was her MI? Why isn't she, and she's got a stent. She should be on a blood thinner. Why isn't it on this list? You're the only one that's probably going to go through that list with a fine-tooth comb and catch something like that. So I always say, if you have a certain diagnosis, think about the meds that go with it. If I have someone who's got AFib and going home with AFib, where's their blood thinner? Where's their antiarrhythmic drug, right? You got to be looking for those things. And you'll see we have certain diagnoses like CHF, COPD, that people have to go home with certain things. And there's actually a bundle that you look at as a nurse, and you can go down that checklist. But even if that is not present, you need to know and think about, what should this patient be on when I discharge them? I don't want to send them out into the community without a med that they need that might threaten their lives if they don't have it. I talked about this a little bit. And I think, one thing that we also chart besides, for oxygen use at home, but the PT documentation is really important to have before they go home, so that they can get home care, possibly physical therapy at home. And yes, the patient has to be making progress, or they won't qualify them for home care. They might want to send them to a facility instead. If a person does not have good rehab potential, they won't be qualified for certain rehab units. If they are not able to progress, they will be turned down for rehab because it isn't appropriate. And they will look at, maybe we need long-term care for this person rather than rehab. So those are things, once you get in clinical and you start looking at your patients, when they get admitted, we start thinking about the discharge plan and what might be appropriate for them. And we revise it and update it, and keep physical therapy on board so that they can help us with this, as well as respiratory therapy. You'll see some examples in your book. Make sure you're looking at some examples of how to report care. The one that we use the most is SBAR, situation, background, assessment, and recommendation. When you're making a telephone call to a physician, you don't want to tell them everything about the person. They were born in 19 whatever. You're going to tell them their name and their age, but you're not going to tell them about their gallbladder surgery back in 1960 or 70, right? You're going to say, this is what's happening. This is a little bit of their background, pertinent background. This is their current assessment, and this is what I recommend. And what that could sound like is I have Mr. Smith. He's short of breath. His SATs are in the 80s. He has a history of COPD. He came in yesterday for increasing shortness of breath. When I assessed him, his lungs do have some crackles in the bases, and he's wheezing, also wheezing. I recommend oxygen at titrate oxygen to keep SAT above 90, possibly a breathing treatment, and possibly some furosemide to get rid of the extra fluid on board. So that's how that would be. You wouldn't tell them everything. You would tell them exactly what you're calling, because this is usually when you're calling and getting an order. You would tell them what's happening now. That's not that person's whole history. That's the pertinent history. When you're reporting off in the morning, you'll do a similar thing. You'll give them the pertinent background and your assessments and problems during your shift, and what still needs to be done during the shift to come. Mr. Smith is stable. He's in here for hip surgery today. He has a history of a fall a few months ago. When I assessed him during the night, he can't move that leg. We've got him immobilized, and he's going to go for surgery today. So that would be a brief report that you could tell your charge nurse. If you're reporting off to another shift, you're going to be more, you're going to tell them more. But if you're giving a quick update to your charge or to a physician or nurse practitioner, you're going to be very, very quick. Incident reports, variance reports, when we have any kind of safety issues, we've talked about this, when a person has an unusual thing happen, like a fall, or maybe you missed giving them a medication, or a medication was late, you're going to do an incidence, a variance report, and that is a report that goes to a separate charting system. It doesn't go in the chart. In the chart, you might say something like patient attempted to get out of bed on own, found patient on floor next to bed, right? And then you're going to talk about how they're doing, what you did, patient vitals, all that. You're going to do an assessment and put it there. But then you're not going to say at the end, filed variance report. Don't even mention it. That doesn't belong in the chart. You're just going to go to your system, whatever it's called, either the Midas system or most of them I've seen are Midas, but there are other names for the softwares that they have for variances. And each facility has their own. You'll go to that system. You'll put the report in there about what happened, all the details, all the things. I had the patient with all the yellow gowns and yellow socks and all this stuff, and they still got out of bed, and this is why we didn't get to do our hourly rounding. We were coding another patient, just whatever the story is. And then the quality improvement will look at that. That's a place that we look at and do research on why are we still having falls and what can we do better. So it's separate from the chart. And then I think I've talked enough about this. Handoff communication, SBARs. Look at some examples in your book. Look at some examples that are in Moodle and practice this in the clinical setting. Practice this with peers. Even if you're not giving report, practice it with each other. Give a peer report on your patient using these quick methods so that you get used to doing this. So that the first time you give report in clinical, because you will have some idea of how to do it. And yes, on change of shift, we like to make sure, like say, often you've had the same patient for a couple of days, your fellow nurse has had the same patient for a couple of days. You would not need to give as much to that nurse because they know the patient. But what you would do is you would update them on the current status, on the current orders, anything abnormal that happened during your shift, any orders that you have not been able to complete that need to be continued. Maybe you are giving a unit of blood that isn't complete yet. They need to complete the blood and get a CBC afterwards, right? Report anything about the patient's or family's concerns. Make sure that any transfer or discharge information is passed on to your peers. I've talked about this enough. I will say when you're calling a provider or physician, mid-level provider or physician, make sure you identify yourself clearly, the patient, State who you are and what your relationship is to the patient. And know that sometimes if it's 2 in the morning, you're not going to be talking to the attending physician. You're going to be talking to that physician's partner who doesn't know the patient. So you might have to give more information. Other times you'll be talking to the physician that's known this patient for 20, forever and has been taking care of them, and you won't need to say as much. So understand who you're talking to. Often they will tell you, I'm on call for Dr. XYZ. I don't know this patient. Often they will tell you that. Before I call any physician at 2 in the morning, if I've got somebody who's complaining of anything and I need to call the physician, I get a set of vitals. I quickly do a quick updated neuro assessment. I just make sure that I've got a current status. I listen to their lungs. If they're short of breath, I listen to their lungs right before I call them. I get a set of vitals that are current. The last thing you want to do is call the physician or mid-level provider and not have any of that information at hand. I get the latest vitals in front of me, the symptoms that I want them to know about. And I have the chart nearby because they're going to probably ask questions that I haven't thought about. So make sure that you have the information you need before you call the provider so that you don't have to say, oh, I didn't get vitals, let me go get those. Because if that happens, you're going to get hung up on because they're at home asleep and grumpy, right? Wouldn't we be? So have your information, be concise, record your call in the documentation. Some things that we do get consultations for other physicians. Say the physician caring for this patient is a general physician and they want to bring in a pulmonary physician. You do not make that call to the other physician. That is a MD to MD or, doctor to doctor, basically. Now, if that consultant has not come up to the unit and seen the patient, it's your responsibility. Say it's been 24 hours, you're going to let the physician know, hey, they haven't been up here yet. Did you remember to make that referral, right? If it's an emergency, it should be pretty fast. Sometimes it's the kind of thing that is the next day. So just know that you do not call the physician and say, hey, Dr. X over here wants to consult you on this patient, because they're going to say, I can't take that consultation from you. I need to speak to that physician directly. Purposeful rounding. This is important, and we talked about this a little bit. We basically do every 2-hour rounding in the hospital now. And we do address during that rounding, it's actually hourly rounding. Sorry, I'm losing my train of thought here. Hourly rounding. And during that hourly rounding, RNs, CNAs can all do this. Your charge nurse can do this if they're free and they're trying to help you out. Go in there and say you've got a med to give. Give your IV push med on your hourly rounding. Don't have your CNA do it. Say, I have to go give an IV push med. I'm going to go do the hourly rounding while I'm in there. And talk to them while you're giving the med. You're probably standing there for 5 or 6 minutes pushing the med. What else do you need? Do you need a position change? Do you need any of your possessions nearby? Do you need to go to the bathroom? Are you having any pain, right? We're going to address those needs, talk to them. Don't just stand there and not speak to the patient or stand there and stare at your phone. Engage with that patient. Get your assessment in. Clean their room up if it needs to be cleaned up. Often you'll have time while you're doing that. Ask them if there's anything else they need, and tell them when you'll be back. And then, of course, if it isn't documented, it isn't done. So make sure you document the round. So I hope this has helped a little bit with documenting. You will continue to learn things about documenting throughout your career, and there will continue to be new forms and checklists. But always document with an eye towards, if I don't put this in here, nobody's going to know I called this doctor. Nobody's going to know I took care of this. Document what you do. Trust me, it will save you so many times. Okay, thanks guys. See you in class.